Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. Okay, we're back. We're delayed, a little bit delayed today, but I'll probably post this tonight. We don't have to take blame.
I know, but if we were, it is my fault.
Yeah, I tried, but for good reason.
I know. I tried. I really hoped that I would be available yesterday until I wasn't available. Like I forecasted I wouldn't be available, and then it played out I wasn't. I still waited an hour to tell you I wasn't.
Did you think that they weren't going to win?
Okay, no. So I was out of town with two of my three kids played in a soccer tournament, and it sounds like, oh my God, you got to go away. Like, no, it was mass chaos. I got off on Friday, 3-hour drive, trying not to stop. Nobody can drink anything. We had to get to the hotel for one of my 11-year-old's friends' birthdays was that day, and there was cupcakes in the lobby at 7. Do you think I got there at 7? No, I didn't. But anyway, it was a girl, it's an 11-year-old girl and a 15-year-old boy, and their teams were staying at different hotels. So I had to pick a hotel. So I heard about the whole time there why I didn't pick the other hotel. And then there's group dinners, and the group dinners are 30 people.
Oh.
But my son's team won their first game Saturday morning. And one of the parents said, oh, I think that was the hardest competition. And they won 4-1. It was easy. And at that moment, I said to myself, we're going to be here till the finals on Sunday. I knew it.
You knew it.
I knew it.
Yeah. You know ahead.
And we were,
but it's good for them.
But it's soccer, and they the finals were at 2:15. It didn't start till 2:30. The game was supposed to be over at 3:30, but they went into overtime, so now it's 3:45. Then they went into PKs.
Oh my gosh!
And it was supposed to be 5 PKs, but they kept making, and then it was 7 PKs. So they won.
So every possible game extension.
Well, so they won, and then we had to do the award ceremony. So we ended up not leaving until whatever. So anyway, long story short, we're back.
We are back. Yeah. Yes. How was your week leading up to that? I mean, that was an exciting part of your week too, but
no, that was good. It made that last week flow right into this week, literally. But no, it was good. Last week, there were items on my list that had to get done a very certain way. And I will go into it more with this episode because it's kind of what this is about. I had stuff on my list that had to be done a certain way so that I could go away this weekend to do the things I had to do and not have the lingering work stuff.
But you were still stressed, I'm sure. You were still thinking about it.
It was so dramatic. It was so dramatic. So the things that needed to happen ended up happening, but oh my God, so convoluted getting there. It was ridiculous. But I'll tell you guys all about it. But no, the week last week was good. We had great surgery days. So 3 clinic days, 2 very full surgery days.
Yeah.
Did another Misha in 40 minutes. That was
awesome. Was that your fastest Misha?
It must have been.
Wow.
It must have been. It was
rapid Misha.
No, it was smooth. It was great.
Smooth, rapid Misha.
Yeah, it was good. That's what they all should be, smooth and rapid.
They will be. That's what's happening. Yeah.
But no, it was good. Yeah. So good cases, interesting, challenging, and in very different ways, but all good. What about you?
I love that. Yeah. We were slated to have a pretty busy week, and then we had some big cancellations at the beginning of the week. And I always hate that because it was a case that we were prepping for months, and then, they got sick and canceled, and then a full busy day ended up being a pretty light day, and that's a little sad. And then had my walkabout day Wednesday. Thursday, I'll briefly get into this. This is a whole other thing. I have a patient that I saw probably 5 months ago. Came into my clinic. I think I actually got him from you guys. This is how we inherit. I don't know why, but all of the craziest unhinged things are always some from y'all's team reaching out and being like, hey, we're not going to take this. Can you actually take this? So it was a stab wound.
Okay.
So stab wound. The guy had gotten stabbed 7 to 9 months before seeing me.
I thought you were going to say times. I was like, go on.
I don't know, maybe 7 to 9 times. We didn't get into detail. I didn't ask him that question. I was not very thorough with that. But yeah, he had gotten stabbed in his arm and it severed his radial nerve. And so he had a complete wrist drop, radial nerve palsy. So I see him again 7 to 9 months later and no function. This is the first time he's getting any care for it. nerve injuries like that are typically best dealt with acutely. If you're looking to try to repair it at that far out, it's not impossible, but it definitely makes it more challenging. So I examined him. We kind of came up with a game plan. We're going to try to repair, but we, in order to do that, needed to get this very special nerve graft because you probably won't have the length that you need at this point. And he also has a neuroma or a painful nerve bundle. Yeah. So we're going to excise that to at least help with his pain, repair if possible. So we get this whole thing coordinated for this big case. The guy unfortunately lives in like, I don't know what you call it, but he's in rehab for like addiction facility.
Yeah, he's inpatient. Yeah, he isn't, or halfway house.
Well, yeah, like halfway house. I don't know. Is that the PC term, halfway house? Probably. But yes. And so you can only communicate with him through that facility. He like doesn't have a personal phone, which makes things challenging.
And you were not given this information when we referred this patient to you.
Correct. But all this still fine. I would hope that a facility like this would like coordinate with the people that they're with. Clearly they don't. So getting him scheduled in the first place was like very challenging. Got the graft ordered, had everything set to go. He was scheduled. We had like confirmed the time and date with him and the facility. And come the day of surgery, this was sometime in December, I believe, that this happened. He did not show up. He was not there the day of surgery. He eventually showed up as we were like leaving the hospital 4 hours after his slated arrival time and had eaten.
Oh my God.
So we're like, okay, we can't do the surgery. We decided to give him the benefit of the doubt and say like, hey, you can get back on the schedule and we'll try to re-coordinate, but like, it's obviously not happening today. He no-showed my appointment for that.
Stop.
Yes. So, in my mind, I'm like, all right, we're done. Like no-show too many times, lost trust. Like this is not happening. Because from our perspective, like that's a big deal. That's a big 90-minute scheduled case that we could be doing something else, an expensive graft, like all these things that go into it.
Big no-nos across the board.
Yeah. So fast forward 2 months later, one of my clinical assistants sees him on my schedule and is like, hey, did you okay this? I'm like, no, thought we weren't seeing him anymore.
Right.
We still decided to give him the third chance. I order a nerve test at this point because we're thinking about the potential of having to do nerve transfers and we need to make sure his function in the other ones is good because his exam was kind of weird. So I order a nerve test. He apologizes to me profusely. And he's like, hey, I'm so sorry. Like all this happened. I wasn't there. I will be there next time. And I'm like,
and you believe
okay.
Him? Yeah,
no, I didn't believe him, but like I wanted to.
Yeah.
I wanted to. So we get him rescheduled. I make everybody like hyper confirm with the facility, like he will be here this time. I still schedule him last case of the day regardless because I know. I know. The day before he's scheduled for the EMG, the girl who's going to do the EMG reaches out to me and is like, hey, he no-showed. And I'm like, oh my God, he's not coming tomorrow. He's not coming.
Oh my God.
He's not coming. And then he didn't show up.
Oh my God. So you
I
you are in this guy's like addiction profile. He's making empty promises to you and you believed him because you wanted to. So
like,
bad.
do I need to go to a halfway house?
I don't know. I think
for whatever disorder I have because of this.
No, it's not your disorder. It is, they have support groups for loved ones of those that have addictions for this exact reason. Oh my God. I give them 100 chances.
I need a support group for all the things happening in my life at this point.
Wait, so you didn't do it and
we didn't do it. Yeah. And now we are at the point where I can write it off, I guess. And it sucks because I really it would have been really cool. Like I would have loved to have seen what came of that.
But if he calls again, like
it's a no. Like I thought it was a no for me last time. I think my team wanted to give him the benefit of the doubt again. I knew deep down in my soul that this was going to happen, but I was hoping every moment. So I talked about it a lot all day to people and I was like, he's not going to show up. He's not going to show up. Because I think I hoped deep down that like reverse psychology, I would be wrong.
Yeah.
But I wasn't.
That's so sad.
Yeah. So I was a little feisty this week.
Yeah.
But
okay.
It's okay.
But you promised to rebound this past week.
Last week, I don't know that I rebounded. I still feel like it was,
like
the week before was good.
Yeah.
This past week, I feel like I had like I was just I was very melancholy week.
Really?
Yeah.
Wow.
I know.
I hit the week like with a plan. So the PA that I work with, he was out second half of the week, and we had a scheduled washout on Wednesday. So this consumed my entire week, because a midweek washout that requires a PICC line is a Friday discharge if everything goes right. If it's not a Friday discharge, it's a Monday discharge. And when you're out of town Saturday and Sunday, it's very, very stressful. So I was like, I need to control this entire situation. So when I had scheduled the washout, prior to the washout, I scheduled blood cultures. Okay. And blood cultures, normally I would get post-surgery, post-washout, when they're in PACU or when they're on the floor. They have to be negative for 48 hours before ID will place a PICC line. I know that, but I didn't want to wait till Friday to then get the okay to place a PICC line, to not get the PICC line, and then not discharge this patient. So I told the patient, Monday, go get your blood cultures. So I told my team, I said, put in blood cultures ×2. Don't put it in one order and then wrote X2. Put it in twice. Yeah. And say, please reference the other order. I am ordering this twice. Right. I like
cover all bases. Yeah.
Over their shoulder, did it, called the patient 8 a.m. and said, go get them now. So the 48-hour result would result on Wednesday, right when she was done with the washout. So I was like, I'm amazing. I've never done that before.
Yes.
Like
I've coordinated perfectly.
I've coordinated perfectly. So the patient's admitted. It's on the day that I'm not operating. So I'm stalking like the Epic system, and I'm like, she's in the OR, right? I get her blood culture results on Wednesday, and it says something stupid like no growth to date. Collection sample was suboptimal, may need to redraw for more volume. Okay. First of all,
I remember you telling me this.
First of all, like you're a lab, like it says blood cultures ×2. So automatically you didn't draw, but you didn't draw 2.
Yeah.
Because you referenced 1, and then you also referenced that it wasn't enough blood. Like, get out of here.
Like, get more blood.
Yeah. But so now that result's going to be seen by infectious disease. And if they agree that it was not good enough, then they would redraw, and then it was all for nothing. Right.
Yeah.
But anyway, I'll pause on that story for now, because it kind of
but so frustrating, because like you're doing all the right things and you're thinking ahead, and sometimes this is just me being negative. I feel like when I think too far ahead and try to do all the right things, that's when disaster strikes.
Yeah. Well, it's like, what is this saying? Like, all good
deeds go unpunished.
Yeah. Or all the best laid plans are, you know.
Oh yeah. They all something. No good deed goes unpunished.
Yeah. It's the same variation of that, but that's exactly how it felt.
Yeah. That is how it feels.
But anyway, so the patient was admitted, they had their washout. I consulted ID, and ID was like, no, we don't need another blood culture. And I was like, oh my God, this is so smooth. This is amazing.
God, yeah.
So fast forward to Wednesday, I see the patient. And then Thursday, I saw the patient. Thursday, the order goes in for the PICC line. Awesome. Great. This is so being discharged by Friday, right? So she gets her PICC line Thursday. I'm reading the notes from case management. Case management just sees her. And it was like 4:00. And then I happened to read a note that's like 4:32, almost 5:00. And it was, the patient, we are in North Carolina. The patient is in South Carolina, right? So infectious disease says, here's her regimen. This is what we're going to do. We're now on day 1 of 42 days, 6 weeks of antibiotics, whatever. We'll need to coordinate with infectious disease in South Carolina to, quote, accept the patient. Okay. Like, I get that. Those that are inpatient here don't want to manage someone who's
not living here.
Yeah. Okay, fine, whatever. Then it says case management to send referral in the AM. Okay. That bothers me on so many levels, but
it's giving no longer a Friday discharge.
So I go see the patient Friday before our surgeries at another site to do her discharge summary. So I'm like, I roll in at 6. I'm like, hey, let's whatever. And the patient's like, oh my God, am I going to go home today? Yeah. I just want to make it clear right now, if you don't, this has nothing to do with me, but this is what I said. I said the referral went in. Sorry, referral didn't go in. It said referral will go in at 8. And she said, oh, well, the infectious disease that I want to go to, they close at noon on Friday.
Oh, great. Okay.
So I was like, all right, what I want you to do is you start calling them. I will have my office, not the hospital, call them, like the infectious disease, and like, did you get it? Did you get it? Did you get it?
Yeah. Wait for this. Yeah.
So anyway, so long story short, Friday comes and goes. It's past noon.
Okay.
I was told at 9:30 referral was sent. 11:30 wasn't received. They sent it again. 11:58. The case management worker was like, "It was sent," like emoji, like smiley face, and I was like, "Yeah, but
perfect."
They didn't accept the patient.
Yes,
they didn't accept the patient. It was sent, and nothing happened. So, again, I'm talking like via Epic at a different facility. I was like, what needs to happen for her to go home today? And infectious disease says, I need someone in South Carolina to sign the home health orders. And I was like, is there a specification with who the someone is? Yes, an MD. Perfect. I call the patient. I was like, you need to call your primary care doctor immediately, explain the situation, and see if they'll sign. So she did. So she said, so I call her back and she said, he said he would. He said, just send the orders, but you have to call him first. And he said, when you call him, tell his staff to, quote, get him out of the room, right? Like pull him out of a patient encounter. Yeah. So I'm in the OR. So now I've got the rep on my phone. I'm telling him what to text my medical assistant to get on the phone to call. My medical assistant continues to be hung up on. And I'm like yelling at the rep because he's like not hearing my phone ding, even though I'm hearing it ding over the suction that we're operating on, right? So he's like, he's reading it and then he's reading out loud that I'm telling him what to say. It's like super annoying, right? Long story short, the doc calls back. We talk to him and he's like, no problem, right? So I communicate that. And it's like just before 4, I told the patient she can go home, right? Yeah. And she ended up leaving for the weekend, but like,
wow.
Oh my God, down to the wire.
Wow,
right?
that worked.
It did work.
As you were explaining it, I was like, there's no way this is going to happen.
But fast forward to today, she messages first thing this morning and she was like, hey, the home health referral, they're out of network. So like no one came to do her antibiotics today. So like, anyway.
Foiled.
No, so, but
it'll work.
The segue from that, hopefully consuming, everything is what we're going to talk about. Yes. So no one would come on and talk with us, aka like our physicians we look up to, those that we
I won't say no one because as I was leaving today and discussing what we were doing, so my doc was like, wait, where are you going so fast? I was like, we have to record. He's like, oh my God, you didn't record already? I'm like, oh my God, how do you not know that? You must not listen.
Yeah, he does. Yeah. My doc was like, why did I not get a new episode today?
No, he definitely pays attention to it. But he did say, he was like, well,
I wanted one of our total joint surgeons to talk about it because, again, I'm not like placing blame, but like statistically, joint infections are going to happen a little bit more than our hand or shoulder or knee, whatever.
But they're also a bigger deal.
They are a bigger deal, and the ones that I remember and are going to talk about are joint infections. Yeah, but no one wants to be the poster boy for joint infections. I get that.
Yeah,
like I'll be a poster boy.
And I feel like there's a thing with it. Like if anybody had come on to discuss this, they would have been nervous that they were about to get plagued with 3.
Yeah, but they're getting playtime for talking about infections. Like nobody wants to be known and like
for talking about that. Like, you had one?
Oh, let me associate your name with joint infection.
Yeah, totally. I get that.
But anyway, so we'll talk about why we hate them. I mean,
more than just the obvious reasons.
Yeah, I mean, nobody loves them, but it's just like whether it's happening in real time or it's happening over the phone or you're reading labs, like we'll talk through the process of the reality of it. Like you do the patient's pre-op. Yeah. You educate them. You say the word infection as a risk, but it's hypothetical. It's not going to happen to you.
And so, like, what is your verbiage? What do you say when you like brush over that?
Okay, so
risk of blah blah blah, infection, blah 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 blah.
Yeah, I know, right?
Risks include death.
And death, right? No, so we preoperatively have our patients wash with benzoyl peroxide, and it very naturally works its way into a shoulder conversation. I will say, and I'm going to send this pre-surgical scrub. This is overkill, but the number one, complication for shoulders is infection, and the infection comes from like armpit skin bacteria.
Do you do pre-scrub for all of your
benzoyl peroxide? Okay. And why did we add that, Hannah? Because of a previous joint infection.
Yeah, I'm gonna just start doing it. We actually had this conversation, so we don't do pre-washes for anybody.
We do just because I want to know that I tried everything to prevent. Yeah, no, so I will say that at pre-op, and I will mention that it's also in their consent, but I don't not mention it. And even for our ACLs, I will say that as well.
Do you guys like give them a bottle at the time?
I send it as a prescription.
Okay. Yeah.
And I give them a handout if they want to buy it on Amazon. And some of them, when they're waiting for me to come in, are like, just bought it, you know?
Yeah.
So.
Yay.
Yeah. And I'll tell them a week before, but I don't care if they do it like once, you know, just like try.
Yeah.
Do something.
Yeah. Some is better than none.
Yeah. Some is better than none.
Yeah.
But anyway, I will work it in the conversation at pre-op, and I will mention that it is a thing, right?
Yeah.
But the scary thing about shoulders is that the way
so
that they
weird.
present,
Yeah.
and again, this one that we had this week is Cutiobacterium acnes or Probranibacter acnes.
Yeah.
I don't know why it like got a promotion and got a name, but it is super slow growing, low virulence. It's not really going to give you sepsis, but its biggest signs and symptoms are stiffness and pain, which is
everybody has stiffness and pain.
Everyone has a variety of stiffness and pain, but the serology is normally negative. So like with Our Lady, and again, I'll work through like, you know, education wise, how do you work up an infection? But Our Lady had negative blood work, right? And then nothing
like ESR,
up.
CRP, you mean?
Yep, CRP, CBC, and SED rate were all completely normal, not like kind of high normal. They were completely normal. And then, you know, you get to the point where you do a joint aspiration and then send the culture. And guess what? The culture takes up to 14 days to grow.
Yeah.
So the fact that I had this lady planned for a washout and didn't have to like drop everything and like whatever is because it took a while to get the result. Like it was crazy. But anyway, it is an art. And for those that deal with orthopedic patients, when someone has an infection, and again, I'm speaking from a clinical brain because I experienced it on my end, not on the patient end, I want to absolve all responsibility. Like, I don't want them to say that it was you infected my shoulder. And for some reason, that's always my biggest fear.
Yeah, no, it is
Or
because
like,
I feel like so much work goes into it to like everything about it is meticulous down to like the draping. I don't want to take it personally.
You don't want to communicate with the patient that
I'm taking it personally.
It's their fault,
right?
Or that it's our fault. Like, you don't want to.
It's nobody's fault.
It's nobody's fault, but you don't want to. You don't want to pin yourself against patient. But anyway, so we like to fix things. Infections are unpredictable. You hope they go a certain way, but sometimes they're so traumatic and it results in so many bad things.
Yeah,
it's emotionally super heavy. The patients, even though you're walking them through like how to treat this, and as they go through it, it affects everything.
Yeah, it makes them like, I don't know, they like lose this trust.
Yeah, but their weight, like their lives change. Like they might not get their full function back.
Yeah.
They might not go back to work. They may lose their job because now their easy recovery turned now into like they pick line and then like oral antibiotics forever.
Deplanting their
but it does test the relationship of the surgical team and then your relationship with the patient.
Yeah.
So those are the things that that hopefully we can.
And it's
talk
stressful
about.
from our standpoint too, because I like typically the PAs are the ones that are seeing post-ops, especially initially. So like the threshold of like when to have concern versus not have concern for it, and like when do you bring those things up, and we've seen that situation go wrong a couple of times, and like how yucky that feels.
Again, for example, and again, when these pop up, God help me, they pop up like in threes, and we have
always
two.
Everything's in threes.
We have two within the past week that affected both of our teams. But like, for example, I saw a patient that was an elbow patient. Known this guy for years. Actually, operated on both of his shoulders. He came in for swelling and redness on his elbow.
Casual.
Added him on the same day, was on the other PA schedule because he had an opening, and he second guessed that. He was like, I don't really see anyone else. I kind of want to see like you. And I just didn't have any availability. I was like, why don't you come in? I will quote pop in.
Yeah.
So the guy had a proximal ulna plate from a car accident that he was in. And he had come in like 5 months earlier for elbow bursitis. Nobody aspirated it. It was kind of like, let's just take a look at it. When he came in, it looked beefy red. It was fluctuant in like a very small area and like really indurated in the rest of it. So I told the other PA, I'm like, all right, just aspirate it. So the PA went in, tried to do it, came out, was like, I didn't get anything out of it. I'm like, dude, there's no way you didn't get anything out of that. So I was like, all right, let's grab the ultrasound. Here's the pocket, aspirate. And as I'm aspirating it, in the clear syringe, you're seeing the color.
Yeah, you can tell.
You know.
Yeah.
So I'm aspirating it, and I was like, well, the nuggets have got to start being laid. So I said, well, this looks a little cloudier than I'd like, aka orange and thick. We're going to send this to the lab. It does look infected. So because you have hardware right underneath there that I hit with my needle, this is kind of a big deal. So let's start you on antibiotics. We'll call you. I'll get, a couple of labs back. The CRP will take probably a day, but let's just, get going on this. And he was like, all right, like, you're going to call me, like, what is the plan, whatever. So again, the patient leaves and there's no real clear plan. Like, I'm not like, I will see you back tomorrow. It's like, hey, I will call you.
Yeah.
Hang in there. Right?
Yeah. Yeah.
So I said enough to alarm him, but not enough to like make him go straight to the ER.
Right.
So anyway, long story short, it was infected. Of course it was going into a weekend, right?
Yes,
so the guy's on antibiotics and he ended up following up with you guys and things escalated really quickly.
Things did escalate very quickly.
Yeah. So
very quickly. I actually knew nothing about this case. Ironically, I don't know if that's the right word to use in this. I was not made aware of this case leading up. The first I found out about this case was when I was called over to the OR to help close because his arm was filleted open.
Yeah, because he required a lot of things.
Extensive
but like the difference, right? So let's talk about that one. That was like, the acute.
Yes.
The guy you haven't seen in 3 years calls out of nowhere and was like, hey,
oh my God.
I'm a little red, right?
Yeah.
So that is how total knees that we'd signed off on 10 years ago, we'll call and say, hey, my knee's kind of swollen.
And you're like,
well, if it's been years, I'm like, patients think they're swollen and they're not.
Yeah.
Like, let's just have them come in. They come in, they're always an add-on. It's not in a spot. And then you come in like this guy and you're looking at it and I was like, this is infected. Like, you already knew it. But you have the acute ones like that. And that goddamn shoulder that we did it in September.
Yeah.
And she wrote us in November, 8 weeks to the day, and was like, hey, my shoulder's killing me. Nothing has changed. I don't know what's going on. And with that patient, again, this is 3 hours away.
Yeah.
I said, go get some blood work. Got some blood work. It came back normal. I was like, okay, it's normal. Get on the schedule. I need to see you in person.
Yeah.
Saw her in person. She looked miserable. So that patient who is miserable, who's kind of painful, kind of stiff, labs are normal. What else do you go to? It's probably your neck, right? So get an MRI. Guess what? It was her neck. It was like a C5, C6, left-sided. I was like, okay, we need to get you in for an injection with your neck, but out of abundance of caution, because your shoulder also is a little jacked up, let's MRI your shoulder. Now a month goes by. This is November. Now it's December. Now it's January. So we get the MRI of her shoulder. It shows like crazy amount of synovitis. So I was like, all right, now you got to come in to aspirate the shoulder, right? So now it's from November, December, January. Now it's February, aspirate her shoulder, and it freaking grew Cutibacterium.
So I assume this was cuff repair.
Cuff repair.
Just start with. So like at this point, are you just doing like IND with the hopes to go back in and then do like
So when I saw the patient
revision
so the patient came in for her MRI discussion / aspiration. And the note on the appointment line said, would like to meet with the physician to, quote, finally figure out what's going on. And I was like, one, offended, two, I'm going in like guns blazing. So I did. I said, listen, you were doing great until you weren't. Your labs are normal, right? The next thing we go to is your neck and your shoulder. We MRI'd, both are abnormal. She actually has a re-tear. And she's got a neck issue. She's actually scheduled for a fusion in May, right?
Oh, geez. Yeah. Okay.
So, but the most abnormal thing is with your recurrent tear, which maybe was attrition. Maybe it was, I don't know what she's doing in therapy 3 hours away, but it's so much synovitis. Like, I need to make sure your shoulder's not infected.
Yeah.
Because if it is, and I had the conversation, I said, because if it is infected, that kind of takes priority. If it's not, then go get your neck fused. Eventually we'll fix your rotator cuff again, right? So what I'm going to do is I'm going to send this for, culture, and then we'll whatever. So she goes back to South Carolina. Now I'm on the phone with her. Now she wants me to call her 3-way back with her husband. Now they want to call again because they now have like 500 questions. So this is like, it's a lot.
Yeah.
schedule her washout. So I educated her along the way, which is crazy because like, had we not MRI'd her shoulder or aspirated her shoulder, she would have got her neck fused and then it would have got another 6 months. Like who knows, right?
Yeah.
So anyway, so I told her, I was like, listen, in person, when it was when it was a negative culture, or I didn't have a culture, it's your neck. Now the game changes a little bit. So now the priority is we wash out your shoulder. We're not going to fix your rotator cuff. We're actually going to take out whatever's in there and pack it with Stimulon Vanco and reaspirate as long as it's negative. Go get your neck done.
Yeah.
Then we'll do your shoulder. We're talking, this will be her whole year.
Dude.
Right?
And I think like patients get mad too because they want to, like, it's obviously natural to, and I don't want to say she was mad or anything, but like they want to put the blame on somewhere. Like, so, why did this happen? Like there has to be a reason for it. Somebody has to be at fault. Yeah.
So she said the like letting her know what was going on along the way was super helpful. She's wrote me back 3 times, even over the weekend. So I heard 3 times this weekend. Thank you so much. You've been amazing. And I'm like, okay, I feel like our relationship is good. But one of her questions was, because I've been so heavily involved, like, has the surgeon done many of these? Right. And part of me is like, okay, if I answer that with
do you wash out a lot of infections? Loaded question.
Yeah, loaded question. Do infections happen a lot? No.
Yeah.
Do we wash out all of them that do? Yes. Mostly, right?
Yeah. Well, you hope, right? All the ones you know about.
But like, you know, the patient is second guessing, right? And then it's like, I'm like guilty because I don't know. And part of Cutibacterium, it's also a contaminant. Like, is it really infected? Did I not send the culture correctly? Like, am I overreacting? Should I try doxycycline first?
Yeah,
like,
those it's hard with shoulders too because of like, because it can be so many other things. I mean,
but also part of me was like, our team telehealthed her 3 or 4 times. Like, we should have brought her back in person. Would I have done anything different had I saw her in person? I can't like X-ray vision see an infection, but like
it's hard even when they're in person.
Yeah.
Gosh, the shoulders are hard. Those are tough.
Yeah. So like, again, after I talked to the patient, I felt good about it. I had asked the doc, I was like, you know, do we wash it out? Should I try doxycycline? And he said, present her aptions and let her decide. But also like, let's wash it out.
Yeah.
You know, so did I...
Whatever you want to do, but this is what you want to do.
Did I appropriately convey the conversation? Yeah. Did I make her feel like I was rushing her?
Did I lead in one direction versus the other? Yeah. Like, is my language leading that you should do this versus not that?
Yeah. But anyway, so that one, we were just at the start of that one. She went home. She got her PICC line. She seems to be happy.
How that's playing out.
She seems to not. We're on the same team right now. Her husband, again. So sometimes you have the dynamic of the patient and their significant other, where the patient trusts you, but the significant other's like, how come you didn't ask this?
Yeah.
Blah, 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 blah. So, I mean, we're all on the same page, I think. But again, that's a lot. Now let's compare that, but let's compare that to a total joint. So total joint comes in, they've been, cleared for several years. They went to get their freaking toes like filed or something, and they get some stupid infection in their toe, and they come in like, hey, my knee's kind of swollen. Haven't seen you in 3 years. I'm like, send a picture. It's kind of swollen. They come in, you put your hands on their knees, and you're like, oh my God.
Yeah.
Like, that's a huge effusion. Aspirate it. You see the sludge coming out.
Sludge.
You're like, oh my God. So let's talk about knee infections. Have you done a lot of knee infections?
No, my experience with knee infections is all via our urgent care. And so I feel like, fortunately or unfortunately, well, definitely fortunately.
Yeah, definitely fortunately.
Haven't had to deal with a lot of those. Yeah. So
when knee infections happen, it is like you see the patient walk down the hall, and if it's to the point where it's just starting, it's like a big effusion. Yeah. Again, you're a PA. You're just a new PA starting out. Maybe you're an urgent care. Maybe it's not your patient. Like, do you aspirate a total joint knee?
Yeah,
right?
and it's also so highly dependent on which surgeon it is and what their response is to that, and like what their threshold is with it. It's tough working with different surgeons and different personalities and different thresholds because they all, one of them might say, if you look at the knee and like any part of you had one half of one brain cell that thought infection, we're going to the OR tonight and we're just going to wash it out. Some of them are like very casual about it. aspirate first, right? And get the cultures. And some don't care about that. And some want pictures and some want you to call them. And some are like, don't call me at 9:00 at night. This isn't an emergency. Like, why didn't you just do X, Y? So it's learning that.
So we collectively have worked with a physician in the past that one suture, like one Vicryl sub-Q suture starts to pop out. This surgeon will wash out the knee. Right? So super aggressive. Okay. Wash out, liner exchange, close it back up. Another surgeon, this joint's infected. I have aspirated a knee, 120 cc's of yellow, brown, orange garbage.
So
I've called and like, hey, so this does not look good. This looks infected. Do you want me to, I'm going to send everything, send for a culture, send for cell count blood work, whatever.
Do you want it added
Do
on?
you want me to inject this guy's knee with a gram of vancomycin? No, let's just see what the culture shows. I'm like, but what if I just injected it with a gram of vancomycin? But some will wait. Some will wait for the culture. Then they'll wait till it's business hours to wash out the knee. And then the physician I've worked with in the past, aspirate it. I know it's infected. Tell them to go home, not eat anything, call the hospital, book the case, inject their knee with a gram of vanc. Like we're rolling on this.
Yeah, no. And those are like, I think personality wise, it depends on like how okay are you having things linger over your head. I'm not. I can't handle it. Like I can't sleep at night and this is the title of this episode, things that keep us awake at night. Yeah. I can't sleep at night if I'm thinking about somebody who possibly could have an infection.
Yeah.
It's just detrimental.
Cannot. Yeah. So, anyway, I've had enough experience with aspirating knees. Some of them I will tell, why don't you just go home, grab some clothes and go right to the hospital. Let me just figure it out. Right. We had one lady who had, she called and said, I've told you this story like 100 times. She called and she was like, hey, my incision's draining a little bit. And I was like, all right, come in. So she came in. She couldn't not hold it. There was like yogurt colored stuff pouring out of her knee.
A little bit.
A little bit. And I was like, oh crap. So cultured it. And what we ended up doing, I think we cultured it. At the time, I think it built up. I think it was like a scant bit of whatever. The next day, half of the wound dehisced. By the time she went home, because again, she doesn't drive, she's living with her sister, whatever. She texted me that night and said, hey, I think some of the stitches are also coming out. She sent me a picture of the metal in her knee because her skin was wide open. And I was like, that happened quick. Yeah.
You're like, go to the hospital right now.
Oh gosh. This was like midnight. Admitted the patient, started her on antibiotics, IV antibiotics, washed her out the next day. There's not enough skin to close. Like she ended up having 3 or 4 revisions and she kept asking me like, but Home Depot needs me to come back. Like, when am I going to go back to Home Depot? And I'm thinking in my head, like,
I don't know that's happening.
Never. Like,
Jesus.
Yeah. But anyway, so they keep you up at night because they're just so,
or they make you not go back to sleep.
But all right, so let's talk about things. So ritualistic process to minimize risk of infection, right? So pre-op optimization. You're not going to take your, uncontrolled diabetics, your pack-a-day smokers, right, to the operating room and think that your risk of infection is low.
Yeah, okay? No, it's not. And I always have like the increased risk conversation with those people. Actually, we're about to do a total shoulder tomorrow on a lady who's on hemodialysis. So
yeah, I mean, but again, that like that's raising some different
so you're going to be like so much more cautious about it. So in my mind, I'm like, we're taking all the measures. We're not going into this with blind hope. Like. Yeah. It'll be fine.
But isn't it crazy though that like you will take all the measures with her and she'll be fine, and then you'll take all the measures with like your stud, regular, that's like super athletic, super clean, everything's clean cut, and he gets an infection.
I know
it's not fair.
It is not fair.
Yeah,
but I mean, like down to a T. So you start that. Just from like a patient optimization standpoint, or at least from our perspective, because I know some surgeons are very, very strict about, I will only operate within these parameters. BMI has to be under a certain level. Definitely not smokers,
A1C in the sevens or below
below
seven, right?
and what's the other thing that I'm thinking? Like MRSA status, like totally negative.
Yeah. Yeah.
Some people, not so much.
Yeah. Some people think those are important. Some people think they're less important.
Yeah. No, and I still think they're important, but I think they're like, I don't know, my approach to all this stuff is a lot more risk mitigation and education.
Yeah.
Right. Because I also get that, like, now granted, BMI is not as important for shoulders per se.
Yeah.
It doesn't put as much risk as the knees and hips. But smoking is obviously still a risk. Do we operate on people who actively smoke? Yes, we do. Do I tell them beforehand, you're a much higher risk of having wound healing complications and a joint infection? Yes, I do. Will that help us, though, when it's 10 o'clock at night on a Friday and somebody calls and sends us a concerning picture?
Yeah.
No, that's still going to make for a shitty weekend.
So, you know what's crazy about it? It's always 10 o'clock at night.
Yeah.
It's always when you're going to go out of town.
Oh, it's always. Yes, we have to touch on that too.
Yeah.
Nighttime, definitely a thing. I actually took a call, it was like 3 months ago now, just to speak on how over time this starts to like ding your, it raises the flags. And I'm on call. I get a call at 3 a.m. from one of our total shoulder patients who I haven't seen in 2 months because he's like appropriately post-op where we're not following him that closely anymore. Calling, he's like, oh my God, my shoulder's just killing me. If somebody could call me back. And I'm like, oh my God, he's infected.
Yeah, he's infected.
My God,
yeah, he's infected.
I call him first thing in the morning. I'm like, what's going on? I mean, not great, but still better story. He dislocated it spontaneously and then went to the ER and they reduced it. So that's actually a win in my book. I'd much rather that. Easier fix.
Yeah, definitely.
But it is always the vacations.
Yeah, we had a guy that it was an infected knee. He came in, we aspirated his knee. Again, I'm just pause real quick. If someone you think is infected, SED rate, CRP, CBC.
Yeah.
Blood work.
Yep.
If you think something is infected, you culture it, send it for culture, you send it for cell count. The first thing to come back is your cell count. And you will get the neutrophils, you get lymphocytes, you get red blood cells, you get all that. You know, based on your neutrophils, where you're at. Yeah. So that's, that for those that are listening and like the textbook answer, I don't know what that is, but the real answer is get your damn cell count because that will come back the fastest and you can move from there. The culture is confirmatory and it'll kind of guide you with what antibiotics you're going to use. But if you see it, someone who has a joint infection looks miserable. And when you get to the point where they look miserable, it's too late. Yeah, it's too late. But anyway, so, oh God, I lost my train of thought.
The vacations.
Okay. So we saw this guy, aspirated this guy. I knew it was infected. And we admitted him to the hospital he wanted to go to, which is a rural hospital. They freaking airlifted him to another hospital.
Oh my God.
When and these stories always go like this to some extent. The guy was admitted to another hospital and ended up washing out his knee. So washed out his knee. I believe we took all the hardware out and put in like a big old cement vancomycin block where he was going to walk on that for X amount of time while I got his PICC line. While he's in the hospital, he develops neck pain and he can't move his arms, right? And I'm like, all right, he had a stroke, something. MRI his neck. He's got this massive tumor.
Oh my God.
On his neck, like something that is like terminal, right? So now he's in the hospital. Now you've got all these other teams involved. In the midst of all this, he becomes septic, right? Anyway, long story short, he died. Guy was admitted. We washed out his knee. The knee stuff, he was already with infectious disease. We kind of had our plan ready to go. Then it escalates into the neck thing. Then it escalates into he can't move his arms. Now he's got terminal cancer. Anyway, so they're consulting me about like his dressing change. Can the guy shower? Now one was going out of town. 2 was already out of town. 3 lost my voice, right? Oh, so I am on the phone and I'm like, I need you that I cannot communicate because I have no voice. And I remember yelling in the phone.
Because you also always get sick before you go on vacation.
Always go sick, yeah, because you're trying to do all the things. But anyway, it was like a total mess. I will never forget that.
Isn't like that literally is the worst case scenario of every possible thing that I can imagine.
But I have also been out of town. And again, I've been out of town where like, and I don't go out of town much. Yeah. Just to be clear.
But every time you do.
No, I remember being on the beach and getting a call from one of our providers that was here, and it was something we were watching and it was fine, and then it turned very not fine, and I was admitting the patient underneath my towel and the blanket because it was so windy you couldn't hear anything, and I was like in my little cocoon calling to get a bed for the patient, because that's like what we normally first do. And everyone's like, why are you, what are you
Come
doing?
out from
I thought
under
you
there.
weren't working. I'm like, oh my God, you guys.
Everybody, that's especially when your family's like having fun. They're like drinking margaritas and they're like, come on, like no work allowed. And you're like,
I'm literally like a turtle under the blanket. And I was like, nobody talked to me. Like, why hotspotting to my phone? Crazy.
Jesus. I mean, but like, I don't know. Like obviously we care.
Love it. It's so chaotic.
Yeah, it is so chaotic. We love the chaos of it. It's like drinking our uncovered coffee in the car.
So another crazy thing about orthopedics is and I've done it both ways, we require infectious disease to help us. Okay. They're going to collaborate with us. I would rather, like we did with this lady, tee it up. Blood cultures are negative. Here's your bug. Just tell me what antibiotic we need to do and send them home, right? They will manage like the weekly blood draws. They'll take the PICC line out. We have gotten so fed up with infectious disease because orthopedists sometimes clash with infectious disease as far as how a problem should be treated. Okay. With like a total joint or hardware in the shoulder or whatever. We want to remove it. Take it out, wash it out, take it out, wash it out. Yeah. Exchange it, don't exchange it, whatever. Infectious disease is like, no. You have to keep that. You have to keep it. Don't start antibiotics until you know what the bug is. No. Where I'm like, no, they've already been on Banco for 3 days.
Sorry. No. That ship has sailed.
This has got to be culture specific. And I appreciate them. But even the lady that I had, I was like, oh, she's going to be on this med. And they wouldn't give her this one med because it interacts with 2 of her psychotic meds that she takes.
But that's methodical medicine. We're practicing chaotic action medicine.
So we have said in the past, screw this. Yeah. We are going to do this all ourselves. So we've washed out a patient at an outpatient surgery center and sent them home. We put Vanc in their shoulder. They're good for like 10 days. Now the doc says, order the PICC line. I'm like,
the outpatient PICC line placement. It's never easy to coordinate.
Okay, so order the PICC line, fine. Now PICC line is in. Home health will do the first dose of antibiotics. But wait, you can't do the first dose of antibiotics. You have to be at an inpatient facility in case there's a reaction. So then I have to bring the patient back to our surgery center so one of our nurses can administer the antibiotic that, guess what, is already in their shoulder. And I know they're not going to react to.
Because it's there.
Yeah. So then coordinating the weekly blood draws.
Like the Vanc trough stuff.
Yeah. Or like, the Cedrate CRP as they go weekly. Then having the patient come back in because we don't want to do home health. We just want home health to deliver the med. We want them to administer their IV antibiotics. Right. So I've shown a patient how to flush their line, how to put saline in the heparin. And I was like,
you could work an ID.
Yeah. And then I've had them come in for their first dose, literally tape it on the wall. You should ask one of our medical assistants. We did this like COVID time because I didn't want to admit them, right? And then removing the PICC line. Done that too. So we've done that, and it's just, infectious disease when they're involved, way easier. But like, there's a little bit of a clash sometimes.
On you, yeah. But like easier in some ways, harder in other ways. Yeah. Sometimes it's easier, even though it's more work on your end, to just be in control of everything. And I feel that for a lot of things.
Yeah. So do you feel like in any of the infections you've had where it needs to be a washout or something, like what role do you play with a patient? Like, is this like the surgeon handles it and you're just like doing the things, or are you like all in?
I personally feel all in, but I feel like we have a very collaborative relationship, less like.
But like, I guess what I'm asking is like when the patient inevitably hits their rock bottom and needs to like,
like you mean who's talking to who's the patient that the mutual patient we're discussing for 45 minutes on the phone, and you're asking who's doing that.
I'm asking.
No. But like I feel very much like I need to take ownership of those situations, like do something, because I know that it's so bad, and like the surgeon is always going to hate it, and it's going to make them stressed out, and it's going to make them on edge and like not happy and not super nice. So like, I'm trying to alleviate that as best I can and like take away whatever badness I can from it.
Well, I think no matter what we hold mentally, the surgeon holds more of that.
Right.
Because they're the hands. Not that we're not the hands, but like they're the
comes back.
surgeon.
Yeah.
You know what I
Like
mean?
that's
So
their
if someone wants to
thing.
go online and blast them, they're not like that goddamn PA.
I mean, they might still.
I know
Who
they might
knows?
still. They
but
probably will.
Yeah, ultimately it comes down to that.
But I think if you're handling the emotional baggage of the patient, the surgeon has whatever emotional baggage that they have from that, just from it happening,
times
right?
300.
But normally, like my method is explain to the patient these things happen. Like they happen even if we control for everything. Now we as a team are going to go through this. Like we're going to tackle this. We're going to get through it. And again, this is not something you caused. It's not something that happened because of whatever you did or didn't do, or, you know, you showered too early or too late or something like that. But also talk early. Like I will vaguely outline, like we're going to wash out the shoulder, and that's step 1.
Yeah.
Step 2 is usually the PICC line. Step 3 is probably a course of oral antibiotics. Step 4, re-aspirate, make sure it's gone. And also with the total joints, some of them, like they're on long-term antibiotic suppression.
Yeah. And I think that's what we're going to do for actually, my doc talked to one of his ID friends today, and apparently we don't need to keep them on lifelong, but they do need to do chlorhexidine scrubs before their hemodialysis. So, but yeah, I mean, I think the patients who, and this is something that I personally like, I don't want to say take pride in, but like, I think it matters and makes a huge difference when something like this does happen. I'm all over it. Like they're becoming my new best friend. Yes. We're going to talk on the phone daily, and I'm going to be very receptive to them. And like, I'm going to stay on top of it. They're not going to feel like I don't care or am not involved. And I think that helps them like appreciate, okay, they don't just not care about me and like, oh, it got infected. And they're like, whatever, go die off in a corner somewhere, you know, like, no, you're now my number one priority.
One of the things that we will do in our clinic is when they come in for their post-ops or their wound checks or whatever, the second they check in, they come back. Yeah. Like they do not wait. We just bring them back, and
you're going to have a red carpet experience.
You are,
here.
but like
not that you want an infection to get that, but
no, not that we're like making up for something we did. Like it's not anything like that. It's just that now you're going to come back frequently. I don't need you to pile on top of everything you're going through. I don't need you to hate it too.
Yeah. Oh my gosh.
You know what's crazy though? Like, have you ever gone through, like when you're seeing a patient, you're like, this is infected, where you're saying to yourself, this is infected, but it takes you like a minute to like verbalize it, or you convince yourself it's not? Like this is not
like
happening.
I'm not, like I'm living in an alternate reality right now.
I'll have like I'll have a little stall where I'm like,
is this happening?
This is happening. Yeah. Is this really happening right now?
And it's the vacations too. I vividly remember 2 very specific times. One that I was like choking because I had to call your doctor. Do you remember that?
Yes, I do.
I was working urgent care, and I was only like part-time with the surgeon I'm with. And I was working urgent care on like a Saturday.
Yes, it was the pinning.
Yes, it was a pinning.
Yes.
And so it was bad. She comes into urgent care, and I'm like, holy crap. So I start calling the doc that I am working with, and he's literally in the air flying. And in my mind, I'm like, why don't you have in-flight Wi-Fi?
Yeah. Why would you, why are you making yourself unavailable for me
like,
right
come
now?
on.
Yeah.
In the friggin' air. Jeez. Be available 24/7. No, that's unreasonable, obviously. But I ended up trying for a long enough period of time that I eventually caved and gave in. And I was like, what do I do?
Yeah.
So I called your doctor, and we washed it out on a Sunday the next day.
I remember that.
Yeah. And I mean, it wasn't a total joint or anything. So at least there's that. She actually is fine now and got better, and she still does her same job, and all is well. And then literally another time where, when you guys go on vacation, like, do you try to plan them at the same time as your doc so that like you're out at the same time or different times?
We try to stagger it. And in fact, it's funny you said that. I got an email today of when our doc is off in the summer. He takes 1 week. It's either it's 4th of July. It's either before 4th of July or after. So this year, 4th of July is on a Saturday. So I was like, oh, cool. He'll probably take last week of June or
the first week of July.
The first week of July. So I am taking the 11th through the 18th. So it's like
second week of July.
He sends a message today. He goes, I'm off the 12th through the 19th. I'm like, you motherfucker.
Like, that was mine.
But I booked this in December. I was like,
yeah, it's good and bad because
it's good and bad. And we decided we're going to leave it alone.
Yeah, leave it be, because you know what? Like, I can't do anything by myself either, other than call your doc.
Yeah.
So like, it works out sometimes better that way. Again, like, these things happen to everybody. Like, there's no ortho team out there who doesn't deal with infection. Infections happen to people. Even if you do all of the right things, they can still happen. And so it's better to just have a good system for dealing with it and be honest with yourself and recognize it.
Yeah.
Right?
But I think preventative, obviously doing as much as you can to control the uncontrollable, right? So making sure your smokers try to quit smoking, right?
Yes.
Making sure those
A1C
that have
is stabilized.
A1C is optimal. Making sure those that have an elevated BMI, maybe they decrease that a little bit, right?
We swab for MRSA for our totals and they treat differently for those. Side note, don't inject olecranon bursitis with steroids.
Don't do that.
I've seen it a couple of times where it has been done and we wash it out. That's what ends up happening. Because I get brown things that come out of the elbow after that happens.
But I think I think if you ever want to test your relationship with a patient, involve yourself in a joint infection. It unfortunately is, it's one of those things. I think that it truly defines you as a great PA because you'll be brought closer together. You'll be closer together, but you're also navigating a situation that is not like you're slam dunk as your post-op care. You're slam dunk as your diagnosis. This is uncharted territory and you got to manage it because the patient's looking to you for reassurance and let's tell me the other ones have gotten through this too, so you really need to take the reins on that. But also, with the hospital stuff, when you're coordinating with other teams, God help me.
Coordinating with other teams and coordinating with the hospital is I don't know, maybe I just have not been lucky recently.
No, I think when it said at 4:00, we'll send out referral in the AM, I was like, oh, that's funny. My AM is 6 a.m. I'm going to start bothering people right now. Right. Their AM was 9:30. Yeah, their AM was 9:30. I was relentless. And had I not said for our lady that we just had, what is the requirement? And they were like, oh, we just need someone in South Carolina. I will find someone.
Can I write that I live in South Carolina?
No, I know, but you guys didn't do that. Yeah. I told the patient, I said, I am working for you right now, sister. I will call your primary care doctor.
Do all these things for you.
Yeah. And I think they were grateful because at the end of the day, they would have still been there today. Could have been the whole weekend.
Yeah. But yes. So this was good. Takeaway. It should have a low threshold of suspicion.
Yeah, it should be on your radar and know what to do. As we talked about, each physician will require something else. Will everyone want a knee aspirated? No, right?
Yeah.
Are you expected to do a shoulder aspiration? No, man, those are hard. I haven't done, I did those until I did those. But systematically working through, gathering more information, confirmation, then action.
Yes.
And it's kind of that order sometimes.
Agreed. All right, guys. Well, we'll see you next time.
Bye. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.